to listen to us. And I'm a geneticist. I work at Texas Children's Hospital and Baylor College of Medicine. And I also have trained as a pediatrician. So what happens over time, and after seeing a lot of children with genetic problems and with special needs, the reality is that the majority have a common problem. So I will try to address some of these common problems and tell you a little bit about these. I will need to pause a little bit between my slides so I can allow the translators to help, since many of you, are getting this in Spanish. Next slide, please. Next. When we talk about, also what I actually should have said, that I want to thank the Texas Department of Health. There is actually a grant that allows us to give some of these seminars, and this is really a good opportunity for us to meet with you all in these venues. With regards to developmental problems and children with special needs, we are often talking about the causes for some of these developmental problems. And as you know, there are a lot of causes for developmental problems, things like chromosomal disorders, and that accounts things for things like Down syndrome or bilocardiofacial syndrome, cerebral palsy. There are a lot of rare genetic disorders that are associated with developmental disabilities, and syndromes like Fragile X syndrome, Angelman syndrome, Prader-Willi syndrome. Children with disability could be due to exposures to prenatal infections. There could be a number of things like metabolic diseases. There's some very rare inborn disorders that are associated with developmental disorders. Yet we still have approximately 50% of those unaccounted for. In other words, from what we see in the clinic, children with developmental disabilities, about 50% of them we cannot make a specific diagnosis. We know that there is a problem, and we address the problem regardless, and we still work trying to make a diagnosis. And how can a doctor, help your child, and what do we do to actually give you more information and empower you with more information? What we do in the clinic, first of all, is try to establish a cause. If we can find out what the cause of your child problems are, then we will have the ability to provide you with more tools for treatment and knowledge for you to know what is going to happen with your child. So it is important for us to establish the diagnosis. Once we have established the diagnosis, parents want to know what caused the problem and what is the cause of all these medical issues. And obviously that is also important for you to know what is going to happen in the future. If we can make a diagnosis, we know in advance what problems your child may actually end up having in the future, whether seizures could be a possibility, gastrointestinal problems, heart problems, brain problems. So all of these things are very important for us to be able to anticipate issues. And definitely we need to address the diagnosis so we can help you with the treatment. There are many genetic disorders and that now we have a lot of treatments for. So it is important for us to know what we can do to help your child. After that, what we do is try to come up with a plan and then explain to you a little bit about the condition and what we may consider that you will end up happening in future pregnancies. In other words, what are the chances for the same problem to happen again in your family? Many of you, having had a child with disabilities, are very concerned that this may happen again. And with that information, you can plan, and things can be done in terms of testing or reproductive planning to try to avoid some of these problems in future children. Obviously, the reproductive options, they could be options such as either considering artificial insemination, egg donation, or even doing what is called as pre-implantation genetic diagnosis. Things that also we can do is start planning for testing that may actually give us the information whether your future children may be at risk or have the similar problem. And simple things like taking care of diabetic control. Diabetes can cause a number of birth problems and birth defects. Alcohol, since we know that alcohol is a problem in pregnancy, and that can cause significant problems in the developing children. Stopping smoking, because smoking can cause problems with growth weight. So all of these information are going to help you and try to guide you through future pregnancies. And obviously, one of the important things for us is trying to help you cope with this, since having a child with special needs is a significant issue and is often very, very hard to cope with, at least early on. And we are there to explain how these things happen, and and things that we can do to help you and to help your family. I'm going to spend only a little bit of time talking about genetics, or what causes some of these developmental problems, because I want to spend more time talking about practical aspects of children with special needs. Most of the developmental problems are associated to problems in the genetic code. We always talk about chromosomes, but let me just explain you a little bit what the chromosomes are. Chromosomes are structures that contain all the genetic material that gives all the instructions how we are put together. There are a lot of instructions inside these chromosomes, and it is estimated that 30,000 of these instructions are nicely packed within the chromosomes. All these instructions are coded into this material that we refer as DNA. And there is long stretches of this DNA that contain all this genetic information of how we and your children are put together. The DNA is then packed inside the chromosomes, and each of the chromosomes will contain hundreds of these pieces of DNA. Each cell in the body has approximately 46 chromosomes, and we know that the chromosomes have to be in the right amount, and all the information inside the chromosomes have to be in the right place for everything to go right. If there is any deviation of that, if there is less chromosome material, more chromosome material, if there is a deficiency in an instruction, there is going to be a risk for different medical problems. This is something that you probably may have seen before, or a picture of these, and these are the so-called chromosomes. You can see that the chromosomes, they look like this sort of black and white strip, sticks, and that they all appear, to be in pairs. They are in pairs because each chromosome is contributed by one of the parents. So one chromosome comes from the mother, the other chromosomes come from the father. And the chromosomes are in all pairs from number 1, that is the largest chromosome, to number 22. Then we have what is called the sex chromosomes. And this is the karyotype from a male. There's an X chromosome and a Y chromosome. This is something that we have been using in genetics for over 30, 40 years now. And this is the karyotype that we have relied upon for many, many years. Right now, we can do something a little bit different, and that is called chromosome microarray. And actually, we can look at thousands of pieces within each chromosome, and we can know if there is a small amount of DNA that is missing or is extra. When you look at these, the chromosomes, even if you take the smallest of these black and white band, you can have thousands of pieces of information. In this particular study that now we do, the chromosomal microarray, you can see in such detail that you can break down the single instructions and pieces within the single instruction. So now we can see things that we have never been able to detect with regular chromosome studies. These requires only a small blood sample, not any different to what the chromosome studies used to be like. So a tiny piece of blood allows us to make this particular test. And this is just an example. This is one single chromosome, and this is sort of like the schematic representation of the chromosome and the black and white bands. And this happens to be from one patient that was seen in our clinic that had a loss of genetic material in a part of this chromosome, in chromosome number 1. And you can see here sort of a magnification of this particular area of chromosome 1. And what this is showing you, and I will spare you the details, but here every single dot corresponds to a piece of DNA. And this is showing you that there is all of these different dots here, that they are now moved to the left. They represent a loss of genetic material, what is called a deletion on a chromosome. So this is a technique that now allows us to make very significant discoveries that have been completely impossible up until now. So these are some of the tests that we do in genetics and studying children with special needs, but certainly there are a lot more studies that we do. But what I would like to do today is really spend a little bit more time talking about common problems that children with special needs have. And most of the children that we see in the clinics, they do have a lot of these common medical issues, from psychiatric illnesses and autism, sleep problems, eating problems, gastrointestinal problems. And what I also want to touch a little bit about is planning for the future, and I will mention a few words about experimental treatments. let's sort of go over some of these topics and what are the psychiatric disorders? Well, psychiatric disorders are disorders that deal with mental and emotional disorders, and is sort of a specialty of medicine that looks at mental health. We know that psychiatric problems are higher in children with developmental disabilities or special needs. And just to give you an example, somewhere between 20 to 40% of children with Down syndrome can have psychiatric problems. And we now know that more than 40% of children with bilocardiofacial syndrome have a psychiatric disorder. So these are problems that are commonly seen in children with special needs. We typically try to divide the problems that happen before puberty and after puberty, and because they tend to be a little bit different. We had also found that there has been a discussion for many years that learning disability children may not necessarily have a psychiatric problem. So it's not that this is due to the learning disability itself, it's just independent. So we know that two different problems can coexist or can happen together. This is a debate that has happened for many years, and I think that now it is clear that you can have a child that has Down syndrome and has no behavioral or psychiatric problems, but you may have a child with Down syndrome that has autism. So not all children that have Down syndrome will have autism, and that clearly shows you that there is a difference between what you see in different diseases. What are the common signs of children that have psychiatric problems? Well, and I have to warn you that you will probably see things that are here that all your children have, even the ones who don't have special needs, okay? Just be careful because these are just common traits. Inflexibility, resisting change, stubbornness, repeating the same activity or words, increased activity like tantrums, or flapping of the hands, like in these type of situations with repetitive movements, agitation, anxiety, disruptive behavior, sensory problems, and things like social withdrawal on aggression. Again, these are manifestations of things that we all have, and actually we as adults have sometimes many of these, including, resisting change and stubbornness, but, that doesn't mean that we have a psychiatric problem. These are just signs of, problems that are only happening when they start affecting or altering the ability to function. Also, this gets a little bit more complicated because these may be confounded or sort of getting worse if you have other issues, if you have medical problems, if you have seizures. Children that have long hospitalizations and multiple hospitalizations, children who have hearing and vision problems. And the list goes on, from even having sleep problems, and I will get to that in a minute, having problems with sleep apnea, that also I will explain to you a little bit, and things like thyroid problems. So all these medical issues can also impact on your child behaviors and also contribute to psychiatric problems. So I told you that there are two types of sort of groups before puberty and after puberty. Before puberty, typical, and that's actually seen sometimes even early on in the first 3 years of life, is what is called the oppositional, defiant, and disruptive behavior. This is the children that will, over time, display tantrums, that will not follow commands, and will start becoming disruptive and aggressive to his siblings and to other peers. Another psychiatric, problem that is what is called stereotypic movement disorders. These are just describing a lot of repetitive acts that oftentimes impair sort of like the regular daily function. And typically it shows by problems with self-injuries because, sort of clumsiness, disruptive behaviors, anxieties, making sort of unusual speech sounds. That's something that is common. Unusual sensory seeking, responding behaviors, sleep problems. These are just sort of groups of conditions, and these are things that a psychiatrist or psychologist will have to evaluate carefully. When children are older, and the problems tend to be a little bit different, and actually there is a big component of them being aware that they have differences with other children. Many of the children, the majority of children with special needs, they're smart enough to know that something is different with them. And that actually creates a lot of different problems with lack of acceptance and by their peers, and then a lot of the grieving issues related to that. There are two sort of major groups, what is called the obsessive compulsive disorder, or OCD, and depressive disorders. The OCD are repetitive compulsive acts, and this is something that you see in some children when they start sort of lining up objects or rearranging objects or doing activities back and forth many times over. Sometimes could be hoarding of objects, or repeating words or gestures, repeating words like echolalia, just making, repeating the word over and over and over. Things like depressive illness are also relatively easy to at least spot, because they manifest by depressed mood, decreased interest in activities, and actually these children will look, they're slowing, they're fatigued, they're tired, they're not sleeping well, and they actually may have physical signs of poor appetite and weight loss. So these are kind of signs that allows us to detect on some of these conditions. So obviously, again, I mentioned that many of these features can be seen in certain periods of one person's life. If a child has gone through separation of the parents, or a loss or a death, or of a dear one, chances are that this child may have some depression, but that may be just a situational depression. You're talking more about when this is sort of a baseline problem, and that starts interfering with daily activity and daily living. These also needs to be addressed if your child starts becoming withdrawn, and if start losing self-care skills, it starts showing slower movements. Some of these, your child is not the same child. Your child obviously is going through some different type of situation. This is when you have to start seeking help. Obviously, you have more severe issues, and when mental illness could actually move into having psychotic episodes. This is fortunately not something that is common, but there could be things like delusions and or hallucinations, things like paranoia. But these typically are not common, and these are things that need to be addressed and treated with psychiatric medications. So just a little bit about psychiatric medications, or obviously when a child is going through psychiatric problems, the first thing that is done is trying to work with a psychology expert and trying to do behavioral modifications. And ultimately, if needed, some medications may be included. There is a medication that is very popular that is called selective serotonin reuptake inhibitors. It's kind of a fancy name, but what it is, basically, serotonin is a neurotransmitter that is widely present in our brains. And we know that if we block the ability for the serotonin to be sort of clean out of the system and keep more serotonin in the brain, the number of symptoms or psychiatric symptoms, and that especially health things like depression, actually can allow more serotonin in the brain and can allow a much normal functioning. An example of a drug in this group is Prozac, which is the drug that you mostly may have heard of. And there are some even stronger drugs that can do the work of serotonin, and they can actually help with other neurotransmitters called norepinephrine and dopamine. So there are a lot of medications out there, and there are medications that can be used for help. So one common issue that most parents have nowadays is the issue of autism. And autism is a group of disorders that may actually be more part of a spectrum. And autism can be seen in association with many genetic conditions, and we have learned a lot about these over the past few years. Things like Rett syndrome, tuberous sclerosis, Angelman syndrome, Prader-Willi syndrome, Down syndrome, Fragile X syndrome, and 22q deletion, or the vilocardiofacial syndrome, have been associated with autism. So most patients diagnosed with autism have no other genetic condition, and there is no single identifiable cause for their symptoms. So you can have autism with a genetic disorder, or you can have sometimes autism by itself. We know that autism is very common, and the number of studies that have been shown that autism has gone up very, very significantly over the years. And this is a graph that shows the number of autistic children or autism spectrum disorder in 1,000 children, and this is sort of how over the years this curve has gone up. Many people have now been saying that the incidence or the number of children with autism has significantly increased over the years. Other people say that this is not the case, that all of those cases were there, but our ability to make the diagnosis is improved. So regardless of what the right answer is, we know that this is very common, and it affects to a large number of children. We also know that there is a genetic basis for autism, and that's probably why we see that in association with many genetic disorders. We know that boys are more likely to have autism, 4 or 5 times more than females. We also know that if we see twins, identical twins share the same genetic information. If a diagnosis of autism is done in one twin, there is almost a 96% chance that the other twin will have autism as well. So that tells you that same genetic makeup is more associated with the possibility of autism. And that in contrast to about 9 to 10% in fraternal twins, which is the same as siblings. Now we know that approximately 10 to 15% of these autism cases have identifiable genetic disorders or conditions, and so we can now, given some of the genetic technology and the testing, we can make a diagnosis, but we're still without understanding what is the other 85% or 90%. Autism can happen again in the families, and 4% for girls and 7% for boys if there is only one child affected. However, if the family already has 2 children affected, there is a 25 to 50% chance of this happening again. So we know that this is it has a significant genetic component again. How autism show up? Autism typically has a number of different components, but children with autism have lack of interest for social situations. They have what is lack of sustained joint attention. Let's say you're trying to make your child play, and your child will very, very quickly just be unable to sustain attention. Also has very little interest in signs or gestures. So these are just inability for the child to communicate. Early on, it's very difficult to make a diagnosis of autism, but sometimes what you can see in young children is self-hitting, head-banging behaviors. You can see with some fascination staring at lights or stealing fans, so they're kind of, they like to see sort of repetitive things or playing with certain repetitive toys. And also, things like food refusal is another symptom of autism. So, not, all children that have signs of autism will have autism. It may be just mild manifestations of that. So just be careful with that. And you need to have a good diagnosis made by a psychologist. And why you want a diagnosis? Because you want to provide your child with the right treatment. There is a treatment that is very well known in autism therapy, and it is also applied to many children with genetic disorders that also have autism, autistic behaviors, and that is called ABA, short for Applied Behavioral Analysis. So basically this is based on the idea that you influence a response associated with the behavior. So these are, it's a very, very long and sustained type of therapy, that it just redirects all the bad behaviors or the unwanted behaviors from your child. And it requires a lot of attention. It requires a one-on-one type of care. So this is something that only very specialized schools can provide. But if your child is diagnosed with something in this spectrum, your child could benefit from some of these therapies. What you want to do is increase the ability for your child to communicate by having either more language or signs or whatever the communication may be. Play and socialization, and decrease all these sort of bad behaviors, the rearranging objects, the spinning behaviors, and things like the aggressive behaviors. Ultimately, and this is something that we don't usually like, but may need to be done in certain cases, is using medications. The combination of the educational aspect and sometimes the medications can be very successful. So let me now turn the page to sleep problems. You know that sleep problems are actually very common, and you may be surprised to know that there are studies that show that at least half, if not, sometimes up to 80% of children with developmental disability have poor sleep or sleep problems. So chances are that your child with special needs may have gone or is going through something similar. This is actually a very common concern from the parents that come to visit, the doctor. Sleep is needed for the child to function best. You need sleep to function. Otherwise, you will be cranky, you will be in a bad mood, you will be unable to concentrate on your work. So all of us need sleep. So why children will be different? And you have to understand that, if your child is not sleeping well, he's going to have a lot of different problems that they can act up on. Typical problems include difficulty going and staying asleep, early awakening, morning drowsiness. That you're trying to wake up your child and your child doesn't want to, and it looks dead tired, and that could be a sign that sleep is needed. That usually causes mood irritability. We are all irritable if we don't sleep. That is something that we all deal with. Children typically will have poor attention, learning problem, poor academic performance. If your child is not rested, it's not going to benefit from physical therapy, occupational therapy, or whatever therapy it requires. It makes you more prone to injuries, because if the child is not rested, it will be clumsy and actually can fall, and it can hurt him or herself. It can actually influence behaviors and cause overactivity or hyperactivity and poor impulse control. Over time, obviously this has to be very severe, but over time, sleep problems can cause organic problems. Things like heart problems, problems with the immune system, and even endocrine problems. So sleep, it is very important. Next. What do you do to study if you want to know if your child has a sleep problem? Well, you want to talk to your doctor because there is something known as a sleep study. This is like a study that is very similar to an EEG or an electroencephalogram. They put a number of electrodes in the head of your child, and actually they measure the electric activity of the brain, and they also measure how much the muscles move, and they measure how much oxygen is being processed. A child that has problems with sleep may actually get poor oxygen in the brain, and they may get a lot of restless movements of the legs or the arms, and those are indications that your child may not be sleeping well. Also, sometimes they can, on these studies, they can find that there may be epilepsy. There may be issues with breathing problems like apnea, and I will get to that in a minute, meaning that these children will pause in their breathing, and actually they may actually snore along with that. So all of these are very valuable for you to know about the problems with sleep. And
is it in the head for the electrodes, but they're on the head?
okay. Yeah, sorry. They said the electrodes, not in the head, on the head, Susan said. It's my English. I'm sorry that I didn't want to mislead you. Next slide. So when you have sleep problems, you actually may end up having something that is called, and that's one of the most common causes of sleep problem, is called obstructive sleep apnea. Obstructive means that there is something that is causing an obstruction, typically in the airway, in the passage from the nose to the lungs. Apnea means that there is a brief pause in breathing during the sleep. So a child seems to be breathing normally, but all of a sudden there is a long pause and your child seems to now have stopped breathing. There are a number of reasons, medical reasons and physical reasons why you may have that. It could be because of the face structure, because of the airway being a bit smaller. Could be because the muscle tone is low. One of the main reasons could be associated with large tonsils, and in some children with obesity. What the symptoms are typically snoring, where snoring could be something relatively infrequent and not significant, but if it's it goes on for sometimes hours and is associated with some of these stop in the breathing, it may actually be a symptom of sleep apnea. So typical of these children, similar to what I told you before, is that they are sleepy during the day and the behaviors are bad, and abnormal during the day. So what things can be done to help with the sleep in your child? Well, you need to treat a number of medical problems. Sometimes they could be also heart problems, thyroid problems, could be the cause of some of these sleep issues. So to talk to your doctor and see if there are any medical issue that needs to be addressed. You have to also treat the apnea, and I'll tell you a little bit more about it in a minute. Sleep hygiene. Sleep hygiene means you have to work with your child, avoid caffeine or caffeinated, beverages, which you should avoid, in general with children anyway, like sodas or high sugar, beverages, and try to make sure that your child doesn't engage into playing games or computer games just before sleep. So try to make sure that your child is not overexcited by the time they go to sleep. Sometimes, we don't like that, but when we have to, medications are required. With regards to the sleep apnea, the most effective treatment turns to be the surgery that removes the tonsils and the adenoids. These are like tissue that we have in the throat and behind the nose that sometimes can be large enough that if we remove, that allows a lot of the air to pass through more easily. In a number of situations, we have to recur to a breathing mask or breathing device that is called CPAP, and that has a little plastic tube that go into the nose, and that with a machine that gives pressure and keeps the airway open, and that way your child will get oxygen more readily through that way. Sometimes even changing the sleep position can help, avoiding the sleeping with the face up that actually can cause obstruction from the tongue. Weight management is a big one, and that actually sometimes losing weight can significantly reduce the obstruction in the airway. In some rare cases, like children with Prader-Willi syndrome may benefit from treatments like using growth hormone. When you do medications, the medications that are readily available and that you don't need a prescription for, one is known as melatonin, although you should talk to your doctor about that anyway. And the melatonin typically, depending on the age of the child, but in an average child can be approximately 3 milligrams, and you have to give it about half an hour before they go to bed. The melatonin helps with inducing sleep or sort of setting the sleep. It doesn't maintain it though. Another medication that we sometimes use is called clonidine. This is a medication that is also being used for reducing blood pressure, and is very effective about inducing sleep and causing sedation. You need a prescription from your doctor. This is not a simple medication. It needs to be given in a specific dose and increase, and because it can cause changes in the blood pressure, it can actually, you need to do it with medical advice. Other medications that I have listed are medications that we don't typically like to use, at least not often, unless there are severe behavioral problems like Risperdal. Ambien and Trazodone, those are medications that they have been used in the past, but again, not typically used for children. So the message is that there are a number of things that can be done to address sleep, and ultimately drugs can be looked into it in some extreme situations. So now moving along, some of the other medical problems. One is feeding and gastrointestinal problems. Feeding problems are common in all children with special needs, and sort of going from top to bottom, things like swallowing problems can be common in a number of conditions. Again, Down syndrome, Angelman, Prader-Willi, a lot of the time due to problems with the muscle tone. Some of these swallowing problems can cause the children not to feed properly, or to choke, or because the food or the formula is going into their lungs. So a number of studies often need to be addressed, and your doctor and speech therapist will ask you to do this swallow study, so that way they can see how the swallow coordination and whether there are any problems with penetration of liquids within the airway. Feeding problems happen also when you have anatomical problems with cleft lip and cleft palate. You may have bilopharyngeal incompetence, so that's problems with your palate, and that may cause the food to come back through the nose. These need to be studied by special MRI studies, endoscopies, x-rays, etc. Sometimes the feeding problems could be more behavioral, and then maybe that your child doesn't like certain textures, and that is also something that may require occupational therapy to work with some of those textures in your child. Or could be a combination of all of the above. I think I'm going to move to the next slide, please. With regards to feeding management, obviously, if your child has a feeding problem, well, what can you do to help with those feeding issues? Provided that your child has a normal swallow mechanism, and your child doesn't have aspiration, then a number of things can be done to help with that situation. So one of them is positioning your infant upright. Something that you know, if you feed your child and you put your child in the bed, chances are that you may end up having with some vomiting or some reflux type of problem. So keeping your child in an upright position. If you're breastfeeding, trying to make sure that you get training and you improve the seal of the child's mouth with the nipple to allow proper feeding. In some children that have problems with the palate, you can use something that is called the Haberman nipple, and this is just a fancy, very long nipple that pretty much goes sort of to the back of the mouth and allows children that have clefting and problems with palate to feed much better. Definitely you need to work with the occupational therapies, and then in particular if your child has problems with the muscle tone. Then another thing that sometimes is done is thickening of the formula to avoid penetration of the liquids into the airway. Sometimes if the liquids are very, very thin, like it could be juice or water, your child may choke, but if you have formula and you have mixed the formula with some cereal or some, there are some special medications or supplements, there's something called Thicket, you can actually make your formula thicker and avoid, the aspiration. In terms of getting the foods, you can always try to work with pureed or blended diets. So those are things that can help with management of the feeds. And when all fails, you have to, obviously with your doctor will recommend to put a tube. It could be a tube through the nose, like a nasogastric tube. It could be a tube that goes directly into the stomach. And in some rare cases, a tube that goes directly into the intestine. And as I mentioned to you, gastrointestinal problems are also part of these and sort of a continuation of the feeding problem. And gastrointestinal problems include, the most common one is the gastroesophageal reflux disease, or it's called GER. And children, even a lot of normal children have GER, especially in the first few months of life. This is due to problems with the esophagus, which is what connects the mouth with the stomach, and sometimes there may be problems with the way that this muscle moves. Don't forget that this is a tube and that is a muscle, and the food, as it progresses down the tube, the muscle sort of starts moving and pushing into the food for the food to get to the stomach. So if you have problems with the way that the esophagus move, or if you have these problems with the relaxation of these sphincters in the esophagus, you may end up with a lot of these problems with GER, inflammation of the esophagus, burning pain. Many of you know what reflux is because it causes a lot of discomfort and pain over your chest. And this is something that, if it happens in a child, it can cause chronic irritability, crying, and arching of the back. And sometimes it's associated with vomiting or food regurgitation. This is something that is very uncomfortable. And in some cases of this condition, some of these food can even, that is now going back from the stomach to the mouth, sometimes can even go back to the airway and can cause your child to stop breathing, and can cause inflammation of the larynx, and actually could be associated with asthma and wheezing. So reflux can cause a lot of other problems besides just a gastrointestinal problem. And in bad circumstances, if the food that goes back up gets into the lungs, it can cause a lung infection or pneumonia. There are also some things that can happen lower down in the gastrointestinal tract, and that is problems with the relaxation of the entrance to the stomach, and then when the food goes into the intestine. And there are a couple of things that can happen when this occurs, and this is like what we know as retching. And this is something that often happens when there is this motility or abnormal motility of the esophagus, and sometimes even can be seen in children that have had a surgery called fundoplication. There is another rare condition that is known as dumping syndrome, and this is when there's also problems with relaxation of some of the sphincters that go into the intestine, and instead of going slowly, they just go all of a sudden, and then it causes severe, abdominal pain, sweating, increased heart rate, and it can cause lowering the sugar in the blood of your child. What do you want to know about these? Well, all of these things can be treated, and that's the importance. The number of medications, and I give you the commercial names because they're better known, but the commercial names, many of you may have seen these in the aisles of the Walgreens. Things like Prilosec, Prevacid, Nexium is also a very popular drug that is used to reduce the acid contents in the stomach and then reduce the whole gastroesophageal reflux. In some cases, children that have a lot of the problems with reflux, if it's very severe or the retching, they actually may need this surgery called fundoplication. Basically what it is that they staple the upper part of the stomach to the diaphragm, and they also reduce the size of the lower part of the esophagus just to avoid a lot of the food to come back up. And in some cases it's also done in conjunction with the gastrostomy, where they put a tube right inside the that goes into the stomach. And in some situations you can have like a tube going directly into the intestine. So lastly, for gastrointestinal problems, the one common issue that many of your children may have is constipation. Constipation is fairly common, and more than half of children with special needs have constipation, and they are aggravated oftentimes because of the low muscle tone, or because your child may have maybe not moving around much, or may have restricted ability to move, and also because of all the gastrointestinal problems that I was mentioning to you. There are a number of ways to address these, but what you need to do first, if the constipation is very severe, you need to do something that is called a barium enema study. And that is to check a rare condition called Hirschsprung's disease, where the intestine is not functioning properly because the nerves do not give the right signals for the stools to move along the intestine. If the barium enema is positive, then chances are that your child will have other studies, including measuring the pressure inside the intestine or doing a rectal biopsy. What do you do for constipation? Well, many of you know, and there are fairly simple ways you can address that. One is increasing the content of the fiber in the diet. Sometimes even formulas have fiber in it. So the number of ways that you can introduce formula. You can also put softeners in the in the foodstuff, and things like mild stimulants or lactulose can actually be very helpful. Rarely you will need to get to this stage, but these may have to be done sometimes by you or by your doctor trying to remove stools by hand when the constipation is severe. There are a number of other dietary products like psyllium or metamucil that can be used in sometimes. Also, you can try laxatives every now and then. This is a drug, polyethylene glycol is a Miralax, or also mineral oil that are often used for constipation. Can only be used if your child is swallowing well and doesn't have any signs of aspiration or penetration, because all of these are oily and can, when they get into the lung, they can cause severe problems. Lastly, on intestinal problems is the issue with celiac disease. This is something that now we see a lot in children with Down syndrome. And celiac disease is caused by intolerance to a protein in the wheat that is called gluten. And gluten is found mostly in wheat, but it's also found in barley and rice. So this is something very commonly found in cereals. However, there are things like oat or rice that don't contain gluten, and those can be safely ingested. What are the signs for celiac disease? Well, children that have celiac disease are not absorbing the foodstuff well. So because of that, they don't grow well. They may have problems gaining weight or even getting in the right height. They may have problems with constipation and diarrhea. You can sometimes see abdominal swelling. And typically in children, this can be seen in some cases after they have been exposed to regular food. So your baby having formula, chances are that will not be dealing with this problem. But as you start introducing some of the grains and cereals, later on you may start introducing gluten in the diet. What happens with celiac disease? This is just a picture of a piece of intestine, and the intestine normally has this sort of fingers-like structures, and all the food that comes through the intestine will be absorbed through these different parts of the intestine. If you have celiac disease, your intestine will look completely flat, completely unable to absorb most of the food that can be otherwise absorbed, that in this particular area will have 5 or 6 times the ability to be absorbed. This reduces the area of absorption, and the number of vitamins that especially are compromised when you have celiac disease. So things like iron, folic acid, calcium, or some of the vitamins cannot be properly absorbed in the body. How do you deal with these? Well, you test for it by doing this test called transglutaminase. This is a fancy name for a chemical that is in the blood that is related to an antibody caused by the gluten. And these tests will detect 95% of the children with this condition. When you make a positive, when you get a positive test of this transglutaminase, then you confirm your diagnosis by doing an intestinal biopsy, which is a very simple and not painful test that they can do through endoscopy. And the treatment is very easy. It's probably one of the easiest we have, and that's just taking away the gluten from the diet. And if you go to the grocery store, you will find that there are aisles now that they have gluten-free products. So this is something that now is easier to deal with. Let me just close by giving you some information about treatments. Well, you probably think that in terms of treatment, there is not much going on. We are talking about treating the constipation, treating the reflux, treating the sleep problems. What else is happening? What else is going on? You will be surprised to know that there are hundreds of studies and clinical trials going on at any given time for all these different rare disorders. And for example, I'm going to give you an example of 2 conditions. One is Down syndrome. This is a very worthy slide, but this is just to show you that the doctors in the lab have created 2 different mice that have all the genetic makeup of Down syndrome or Down syndrome equivalent. So these are Down syndrome mice. And why the doctors do that? Well, they want to study what happens in Down syndrome and what happens in these mice, and understand what exactly this extra chromosome 21 causes in these children, and making a comparison with the animal, understand what is going on more. And this also is very helpful to do studies in the animals. For example, there's been recently a study with this the fluoxetine or Prozac. I mentioned to you before, this is one of these serotonin drugs. And these studies, have shown that giving Prozac to mice with Down syndrome were able to restore some functions of memory. And doctors can actually test for memory in mice, believe it or not. And there have been some studies done in children that have not been very successful. There also, this actually talks about 2 different studies. One was this deposition of amyloid plaques. Amyloid is a protein that is deposited in the brain of people with Alzheimer's disease. And some of these studies have shown that the mouse with Down syndrome have this deposition of these amyloid plaques. So, and they have been using this drug called DAPT to decrease the number of amyloid plaques. There's also another drug that has been also used to increase the activity of a neurotransmitter in the brain of patients, with in mice with Down syndrome, and also has been tried now in patients. That is called Aricept. Aricept is a drug that is used in Alzheimer's disease. So far, a lot of these studies have been inconclusive. So a lot is being now find out, but the reality is that now with all these experimental models and all of these medications, now we are able to try to intervene and try to provide further answers and further treatments. I won't spend much time on these, but there is another condition called Fragile X syndrome that is caused by a defective gene in the X chromosome, and patients with this condition have intellectual disabilities, autistic behaviors, sometimes they have seizures. These children, they tend to have very distinctive clinical, physical findings. This is a picture of a child with Fragile X syndrome, and this kiddo has slightly larger head, he has speech problems, he has autism, and a number of clinical findings that are fairly characteristic for this condition. Well, as it turns out that recently the doctors have found and that there is a common biological component in many of these conditions, including Fragile X, and now including things like Rett and Down syndrome. And there is this chemical pathway within the body that now the doctors are trying to look at, and then giving a rare antibiotic called rapamycin, trying to see if they can rescue some problems, developmental problems that were actually found in some of these animal models. And there is actually recently a study that was done with an antibiotic called minocycline. This is kind of an interesting study that there are mouse that have Fragile X, and actually, believe it or not, the mouse seems to have vocalizations. They seem to understand each other, and then when the Fragile X mouse was treated with minocycline, and this mouse apparently have impaired vocalization, and they were able to restore or become the vocalization more apparent in mice. So there is actually a study in Fragile X with minocycline, and that's still going on. So far, they are not. The results do not appear to be, that significant. But this is just to show you that understanding what goes on in the laboratory and some of these animal studies, we can now start making, formulating treatments and thinking about the future and things that can help your children. So I will just go very rapidly. Planning for the future. Remember that all your children that have special needs, and you may have already talked to your social workers, they are legally free under the U.S. law. And so you need to go through this guardianship petition, and so you can become the guardian for your child. This is something that you need to look into it, because you will probably have to provide for a child. And also, if something happens to you, you also need to do a will and then be able to provide for your child when you are not around anymore. There are a number of resources, and I think that you will have in the handout that we will put on the website, but the number of issues that we have not talked about early prevention, preschool and school planning, the number of policies from the American Academy of Pediatrics, and a number of also of publications about family support and what is to raise a child with special needs. There are also some other resources. This is something that is also fairly big that I have not had the time to cover, which is sexual and reproductive issues and issues that also deal with Social Security income, health insurance, Medicaid, Medicare, etc. I think I'm going to stop here because I'm probably a little bit over time. And I thank you very much for being, and for this talk today. Thank you, guys.